unavoidable circumstances, and with the blessings Dr. Respected Emeritus Chairperson, Mahatma Gandhi University of Medical Sciences and Technology, Dr. M.L. Swankar sir, will be starting off with the event. Respect to Honorable Chairman cum Chancellor Dr. Vikas Chandra Swankar, Vice Chancellor Dr. Anchin Kalia, Pro Vice Chancellor Dr. V.K. Kapoor, Principal and Controller, Mahatma Gandhi Medical College and Hospital Dr. M.D. Soni, esteemed senior faculty members, colleagues and dear students. I welcome you all to the 18th UGCR. As we continue with our academic deliberations on the theme of pain abdomen, today's session will address an area of great clinical significance, gastritis and peptic ulcer disease. The discussion will encompass the anatomy and physiology of the stomach and the esophagus, the pathological mechanisms behind the disease, and ultimately concluding the clinical spectrum and management strategies for managing gastritis and peptic ulcer disease. The chairpersons for the event are Dr. Mohammad Sabir Hussain, Professor, Department of Physiology, Dr. Anchin Kalia, Professor, Department of General Medicine, and Dr. Vimal Mathur, Medical Officer in the Department of General Medicine. To begin off, I would like to invite Dr. Anchin Kalia ma'am to give a brief introduction on the topic. Welcome ma'am.
A very good morning, distinguished house and all the students present here. So today we will be talking about peptic ulcer disease and pain abdomen. So pain abdomen, when you start your ward postings, so I'll just touch the clinical part and importance of pain abdomen. So this is for the students. So whenever you enter the clinics, the first thing or the most common complaint which you will face is pain abdomen. Most of you also would have had this problem of pain abdomen sometime in life, right? So why is this important? So pain abdomen can present as a symptom or symptom of so many diseases, and as we see that today the topic of discussion would be the peptic ulcer disease and gastritis. So the anatomy and physiology and the clinical aspects will be taken care of, but I will just touch in brief the importance of pain abdomen. Now suppose a patient comes to you and he says that I have a pain in the epigastrium or upper abdomen. So there are so many differential diagnoses which would come to your mind, and as a clinician you should not miss on the important or the red flag signs which are associated with pain abdomen, and which includes your, so pain abdomen can be because of, like today's topic is gastritis or peptic ulcer disease or simple gastroenteritis or the very ominous myocardial infarction. So you have to be very careful in taking a history of patients who have pain abdomen, just because you should not miss these common complaints which patient has, like myocardial infarction and pancreatitis or mesenteric ischemia. So these are the differential diagnoses you should not miss. So what is peptic ulcer disease and gastritis? So this is a part and parcel of two different phenomena. So peptic ulcer disease is obviously the breach in lining of the gastric mucosa, whereas gastritis is the inflammation. So inflammation can be because of any inflammatory pathology, vasculitis or infection, and most commonly is the H. pylori. So when you come to your clinics or maybe in day-to-day life, or your parents or your attendants or your grandparents would often complain that मेरे को gas हो रही है या मुझे पेट में दर्द हो रहा है. So the most common thing which comes to your mind should be the common is the gastritis, and if the patient is elderly, you should never miss the diagnosis of myocardial infarction or ischemia, right? So we'll further discuss this in the anatomy and the physiology of peptic ulcer disease and gastritis. So I would like to invite the speaker for presenting the anatomy.
Good morning everyone. I welcome you all to the 18th UGCR on the topic Pain Abdomen Part 3 Gastritis and Peptic Ulcer Disease, and I am here to talk about the applied anatomy of esophagus and stomach. This presentation is prepared by my team, that is Diya Balwada, Sabha Javed, Devansh Nagar, Chaman Jain and I, Diya Sethi, along with the help of our moderator, Dr. Pooja Garg, Assistant Professor, Department of Anatomy, under the guidance of Dr. Pankaj Kumar Singh, Professor and Head, Department of Anatomy. First of all, let's talk about the esophagus. Esophagus is a narrow muscular tube which lengths 25 cm. It extends from the pharynx to the stomach and provides the passage for the bolus and liquids during the third stage of deglutination. It commences at the lower border of cricoid cartilage at the level of C6, descends in front of the vertebral column lying behind the trachea, passes first through the superior mediastinum and then through the posterior mediastinum, pierces the opening in the diaphragm at the level of T10, enters the abdomen and ends at the cardiac orifice of stomach at the level of T11. Normally, there are 4 anatomical constrictions or narrowings of esophagus. The first constriction lies at the pharyngoesophageal junction at the level of C6. The second constriction lies where it is crossed by the arch of aorta at the level of T4. The next constriction is where it is crossed by the left principal bronchus at the level of T6. And last, at the diaphragm, which is at the level of T10. Clinicians remember these constrictions as 6, 9, 11 and 15 inches from the upper incisor teeth. Clinically, what is important is that these are the sites which have the highest chances of foreign bodies lodgement. After ingestion of any corrosive substances, there can be stricture development at these sites. These are also a predilection for the carcinoma of esophagus, and comparatively, it is difficult to pass any esophagoscope or gastric tube. The relations of esophagus. Esophagus is typically divided into 3 parts: the cervical esophagus, the thoracic esophagus, and the abdominal esophagus. First, learn about the relations of the cervical esophagus. Anteriorly, it is related to the trachea. In between the 2 tubes is present the recurrent laryngeal nerve, which is the branch of the vagus nerve. Posteriorly, it is related to the vertebral column, the prevertebral fascia and the longus colli muscle. On either side, it is related to the common carotid artery and the lateral lobe of the thyroid gland. 2 very important things to note here. First, if a surgeon has to operate on esophagus, he should go with the left-sided cervical incision, as the left wall of the esophagus is much more easily accessible and more exposed. Secondly, one should take care of the recurrent laryngeal nerve that lies in the tracheoesophageal groove while operating on the esophagus, as damage to this nerve can even cause hoarseness. Moving to the thoracic relations. Anteriorly, again it is related to the trachea. It is also crossed by the arch of aorta and the left principal bronchus. Further down, it is related to the left atrium covered by the pericardium. An important clinical condition related to this relation is due to the left atrial enlargement, which can be due to mitral stenosis, which causes mechanical compression of esophagus leading to dysphagia, a condition also known as dysphagia megalatrensis. In the X-ray picture shown below, we can see the compression of esophagus due to the enlarged left atrium. Coming back to the relations, the esophagus is sandwiched between the 2 tubes, that is the descending thoracic aorta and the azygous vein. Posteriorly, it is also related to the crossing of the thoracic duct at the level of 5th thoracic vertebra. The histology of esophagus. Like any other tubular organ in GIT, esophagus also contains 4 layers: the mucosa, the submucosa, the muscular layer and the fibrous membrane. The epithelium of esophagus is stratified squamous, non-keratinized. What is unique to the histology of esophagus is its muscular layer. In the upper 1/3, it is made up of the skeletal muscles. In the lower one-third, it is made up of the smooth muscles, and in the middle one-third, it is made up of both the skeletal and the smooth muscles. A clinical condition related to the histology of esophagus is Barrett's esophagus, which shows metaplastic changes in the mucosal cells that lines the lower part of the esophagus. There is change from the normal stratified squamous epithelium to the abnormal simple columnar epithelium. It is a pre-malignant condition because of its potential to transform into esophageal adenocarcinoma. Another very important clinical disease is GERD, that is gastroesophageal reflux disease, which is mainly due to reduced lower esophageal sphincter pressure or inappropriate relaxation. As a result, there is acid reflux which injures the distal esophagus. The patient presents with the complaint of heartburn, regurgitation, dysphagia and non-cardiac chest pain which sometimes mimics MI. It is also a precursor for the carcinoma of esophagus. The arterial and venous supply. The arterial supply of esophagus is mainly by three arteries. The upper part is supplied by the artery of the cervical part, that is the inferior thyroid artery. The lower part is supplied by the artery from the abdominal part, that is the left gastric artery. And the middle part is supplied by the horizontal branches of the descending thoracic aorta. The venous drainage of cervical part is mainly by the inferior thyroid vein. Of thoracic part is by the azygous and the hemizygous vein, and of abdominal part by the hemizygous and the left gastric vein. The lower part of esophagus is a very important site for portocaval anastomosis. In condition like portal hypertension, which can be due to any cause like the cirrhosis of liver, there is back pressure in the portal circulation. As a result, the collateral channels open up and they become dilated and tortuous, leading to the formation of esophageal varices. These might rupture and cause hematemesis or vomiting of blood. The lymphatic drainage. Let's consider the lymphatic drainage of esophagus as three safety nets wrapped around the esophagus which are interconnected and parallel to each other. The first safety net, which is innermost, is the paraesophageal nodes, which is represented by the red dots in the diagram to the right. They are present on the wall of the esophagus and they drain lymph directly from the walls only. It is important in the early spread of esophagus as the tumor cells first reaches these nodes. The second safety net is the paraesophageal nodes, which is outer to the paraesophageal nodes, which is represented by the blue dots in the diagram. They are present on the structures adjacent to the esophagus like the trachea, the bronchi, the pericardia or the aorta. They act as secondary linkage pathways which interlinks with the mediastinal lymph nodes. In advanced cancer, the disease spreads from the paraesophageal lymph nodes to the periesophageal lymph nodes. The third safety net, which is outermost, is the lateral esophageal nodes, which is represented by the green dots in the diagram. They are present lateral to the esophagus and they provide the route for the lymph to pass laterally and then to the paratracheal and the deep cervical lymph nodes. This explains why esophageal carcinoma spreads so widely and easily. The nerve supply. The sympathetic supply is by the T5 to T9 spinal segments, whereas the parasympathetic is by the recurrent laryngeal nerve, which is a branch of a vagus nerve, and the esophageal plexus formed by the vagus nerve. Referred pain of esophagus. In condition like acid peptic esophagitis, the pain sensation from the lower end of esophagus are carried by the sympathetic fibers to T4 and T5 spinal segments. This pain is referred to the lower thoracic and the epigastric region, and it is sometimes difficult to differentiate the esophageal pain from the inguinal pain. Talking about the stomach. The stomach is the most distensible and widest part of GIT. It contains four parts. The cardiac part, in which the esophagus opens, the upper dome-like fundus, the main body, and the pylorus, which is further divided into pyloric antrum, pyloric canal, and the pylorus. It has two ends, the cardiac end and the pyloric end, two surfaces, the anterior superior surface and the posterior inferior surface, and two margins, the greater curvature and the lesser curvature. There are two anatomical spaces which are important from the surgical point of view. The first is the Traube space, which is a topographic area over the fundus. It is bounded superiorly by the lower border of the left lung, inferiorly by the left costal margin, from the left by the lateral end of the spleen, and from the right by the inferior border of left lobe of liver. Normally, this space is tympanic on percussion, but any dullness to percussion can indicate either splenic enlargement or pleural effusion or carcinoma, including the fundus. Another space is the gastric triangle, which is in contact with the anterior abdominal wall. It is bounded from the left by the left costal margin, from the right by the inferior border of the liver, and inferiorly by the transverse mesocolon. Normally, a patient is fed through the right tube, which passes from the esophagus. But in condition of complete esophagus obstruction, gastrostomy is performed to feed the patient, as this is the space from which one can easily approach the gastric wall, the stomach wall, without any major organs intervening. The relations, peritoneal relations. Stomach is mainly covered by the peritoneum, except the area with the blood vessels and the bare area of stomach, which is posterior to the cardiac notch. There are in total 4 peritoneal folds. The lesser omentum, which contains the hepatogastric ligament and the hepatoduodenal ligament. The greater omentum, the gastrosplenic ligament and the gastrophrenic ligament. Rupture of peptic ulcers in the anterior wall can sometimes cause peritonitis. The visceral relations. Anteriorly, the stomach is related to the following structures. The cardiac end is related to the left lobe of the liver. The pyloric end is related to the quadrate lobe of the liver. From the left, it is related to the diaphragm, and from the lower part, it is related to the anterior abdominal wall. The posterior relations of stomach forms the stomach bed, and it is formed by the diaphragm, the spleen, the left kidney, the left suprarenal gland, the splenic artery, the left colic flexure, the pancreas, and the transverse mesocolon. All the structures that form the stomach bed are separated from stomach by lesser sac, except the spleen, which is separated by the greater sac. The rupture of splenic artery can even lead to hematemesis. The blood supply of stomach. The arterial supply is mainly by the celiac trunk and its branches, which are the left gastric artery, the splenic artery, and the common hepatic artery. The arterial supply is mainly by the 5 arteries. The first artery is the left gastric artery, which is the direct branch of the celiac trunk. The second artery is the right gastric artery, which is the direct branch from the common hepatic artery. Both of these anastomose at the lesser curvature of stomach. The third artery is the left gastroepiploic artery, which is a branch of the splenic artery, and the fourth artery is the right gastroepiploic artery, which is a branch of gastroduodenal artery. Both of these anastomose at the greater curvature. The last artery are the short gastric artery, which are 5 to 7 in number, branch of the splenic artery and supplies the fundus of stomach. An important clinical point to note is about the gastroduodenal artery, which is present behind the first part of duodenum and represented by the dotted lines in the diagram. Posterior wall duodenal ulcer can sometimes erode the gastroduodenal artery and cause massive upper GI bleeding. The venous drainage corresponds to the arterial supply. The lymphatic drainage. To understand the lymphatic drainage of stomach, we divide the stomach into 4 parts. First, into the right 2/3 and the left 1/3. The right 2/3 part is further divided into upper 2/3 and lower 1/3. the left 1/3 is divided into upper 1/3 and lower 2/3. The lymph from the right upper part drains into the left gastric nodes. The lymph from the right lower part drains into the right gastric and the hepatic nodes. Lymph from these nodes further drain into the celiac nodes. The lymph from the left upper part drains into the pancreatico-splenic nodes, and from the left lower to the right gastroepiploid and the pyloric nodes. The gastric carcinoma is very common in the region of pyloric antrum along the greater curvature of stomach, which is represented by area 2 in the diagram. The gastric carcinoma can also spread to the left supraclavicular nodes, which are the sentinel nodes for this type of carcinoma. These nodes can become enlarged and palpable and known as Virchow's nodes, which is the first sign of gastric cancer, also known as the Trauser sign. The nerve supply. The sympathetic supply is derived from the T6 to T10 spinal segments via the greater splanchnic nerves and celiac and hepatic plexus. The parasympathetic innervation is by the vagus nerve. A surgical procedure in which the vagus nerve is cut to cure the peptic ulcers is called vagotomy. There are 3 types of vagotomy: truncal, selective and highly selective. In the truncal type of vagotomy, the anterior and the posterior vagal trunk are divided. In the selective type of vagotomy, the celiac and the hepatic branches are preserved, whereas the main trunk and the nerve of later jet is cut. There are 2 disadvantages of this type of vagotomy. Firstly, no doubt, these type of vagotomy causes denervation, but alongside they also causes defect in the gastric antrum. Secondly, in selective type of vagotomy, surgeons many a times forget to cut the nerve of Gracie, which is the branch of the posterior vagal trunk which supplies the fundus. And the surgeons often forget to cut this nerve. As a result, the patient comes back with the same complaints of peptic ulcer even after the vagotomy is done. So, clinically, it is a crime to leave this nerve while performing vagotomy. So, this nerve is also known as the criminal nerve of Gracie. The third type of vagotomy is the highly selective vagotomy, which is very particular and denervates only the parietal cells. Also, there is no effect on the gastric antrum. The gastric pain. The gastric pain is often referred to the epigastric region, as the epigastric region is also supplied by the T6 to T10 spinal segments. The development. The stomach originates from the foregut, and this process initiates in the 4th week intrauterine life. It undergoes 2 rotations and finally becomes oblique in position. A developmental anomaly, which is congenital hypertrophic pyloric stenosis, presents at 2 to 6 weeks after the birth and presents with non-bilious vomiting as seen in the diagram. Another condition is hiatal hernia, in which the stomach herniates through the diaphragmatic opening into the thorax. It is of 2 types, the sliding hiatal hernia and the paraesophageal hernia. In the sliding hiatal hernia, the gastroesophageal junction along with a part of esophagus slides into the thorax, whereas in paraesophageal hiatal hernia, the gastroesophageal junction remains in its normal position, whereas a part of stomach, especially the fundus, outpouches from into the thorax. The histology. The stomach wall also has 4 layers: the mucosa, the submucosa, the muscularis externa and the serosa. The epithelium is the simple columnar epithelium. There are 2 internal features of the stomach. First is the gastric pits, which is the invagination of the mucosa which contains the gastric glands, and second are the gastric rugae, which are the large folds in the mucosa which distends when the food enters the stomach. There are 4 types of cells: the mucus cell which secrete the mucus, the parietal cells which secrete HCl, The chief cell will secrete pepsinogen and the endocrine cell which secretes the hormones like gastrin, histamine and somatostatin. This is the video of barium swallow fluoroscopy showing esophagus contracting as barium passes into the stomach and the small intestine. This can detect enlargement of left atrium due to mitral stenosis, esophageal strictures and carcinoma and achalasia cardia. At last, I would like to mention the sources from which I have prepared this presentation. Now I would like to call the next presenter from the Department of Physiology.
Good morning, esteemed dignitaries, respected teachers, and my dear colleagues. I am Neha, representing Department of Physiology today under the guidance of Dr. Aparna Garg, Professor and Head, Department of Physiology, and with the support of our moderators, Dr. Anita Jain, Associate Professor, and Dr. Himanshu Gupta, Assistant Professor. With the help of my team, Rinki Junwal, Pooja Gujjar, Radhika Arora, and Tanishka Verma, I will be presenting on the topic Physiology of Esophagus and Stomach. The learning objectives of today's presentation is esophagus, stomach, gastric mucosal barrier, and the factors affecting it, and the applied aspects related to it. Starting off with deglutition. Deglutition or swallowing reflex is a complex and coordinated process to move food from mouth to the stomach. Deglutition occurs in three phases: oral phase, pharyngeal phase, and esophageal phase. Among this, oral phase is voluntary and the rest two phases, that is pharyngeal and esophageal, are reflux and involuntary. In oral phase, bolus formation occurs with the help of the saliva. Tongue then pushes the bolus into the oropharynx. This phase is under the voluntary control of cranial nerve 5th, 7th and 12th. In pharyngeal phase, food in the oropharynx acts as a stimulus. The signals are sent through sensory portions of trigeminal and glossopharyngeal nerves to the center located in medulla and lower pons. It then communicates with respiratory center, causing deglutition apnea. On the other side, motor impulses are sent and the following responses are produced, like soft palate blocks nasal cavity, tongue blocks oral cavity, epiglottis blocks larynx, and upper esophageal sphincter relaxes. The entire reflex takes about 1 to 2 seconds. This phase is under the involuntary control of cranial nerve 10th and 11th. In esophageal phase, esophagus centers on its function as a muscular tube that transports food from pharynx to the stomach through a process called peristalsis, which uses wave-like contractions. It is regulated by two sphincters, upper esophageal sphincter at the top and lower esophageal sphincter at the bottom, and is under the nervous regulation to coordinate its movement. Here showing you the steps of deglutition through an animated video. Food enters the mouth, saliva then moistens the food and the bolus is formed. Amylase, an enzyme in saliva, starts breakdown of food from mouth itself. Bolus then travels into the esophagus from mouth to the lower esophageal sphincter via peristaltic movement. Lower esophageal sphincter opens and the food enters stomach for further digestion. Stomach acts as a temporary reservoir of food. It plays role in digestion of food by mechanical digestion through peristalsis and chemical digestion through gastric juices. It also helps in controlled delivery of chyme to the intestine. The layers of stomach wall from outside to the inside are arranged as serosa, subserosa, muscle layer, submucosa, and the innermost mucosa. Mucosa contains various gastric glands. Gastric glands are small tube-like structures present in the inner lining of the stomach. The function of gastric gland is to produce and secrete gastric acid, which is a highly acidic fluid responsible for digestion of food. There are 4 types of gastric glands, starting off with cardiac gland, which is a mucus-secreting gland. Next is the oxyntic and parietal glands, which secrete hydrochloric acid and intrinsic factors. Then the Brunner's glands, which secrete the hormone gastrin. And last, the pyloric gland, which secrete pepsinogen and gastric lipase. The gastric juice is a mixture of several important components like hydrochloric acid, mucus, which protect the stomach lining, electrolytes that help in pH balance and enzyme function, intrinsic factors that help in absorption of vitamin B12, water, which acts as a solvent that dissolves food for further digestion, and pepsinogen, which is an inactive enzyme that helps in protein digestion. Here showing you the secretion and function of hydrochloric acid. Parietal cells or oxyntic cells secrete hydrochloric acid into the lumen of the stomach. This is an active process driven by hydrogen-potassium pump located on the apical membrane of the parietal cells. Here, carbon dioxide diffuses inside the parietal cells. It then binds with water in presence of enzyme carbonic anhydrase to form carbonic acid. Carbonic acid dissociates into hydrogen ion and bicarbonate ion. Hydrogen ion is actively pumped out in exchange of potassium ion with the help of hydrogen-potassium ATPase or proton pump located on the apical membrane of the parietal cells. On the other hand, bicarbonate ion is actively pumped out in exchange of fluorine ion with the help of chlorine bicarbonate exchanger present on the basolateral membrane of the parietal cells. Fluorine ion is also diffused out of the cells into the lumen. Hydrogen ion and chlorine ion present in the lumen combines and form hydrochloric acid in lumen of the stomach. The various functions of hydrochloric acid are as follows. It activates pepsin, which is a protein digesting enzyme, creates acidic environment of pH 1.5 to 3.5, kills pathogens, dissolves food particles, and helps in breakdown of complex food structures. The regulation of hydrochloric acid secretions occur by 2 pathways, stimulatory and inhibitory pathways. The stimulatory pathway contains neural pathway, hormonal pathway, and paracrine pathway, and the inhibitory pathways acts by the action of somatostatin and prostaglandins. In neural pathway, vagus nerve stimulate the neurotransmitter acetylcholine, which then stimulates muscarinic receptors, thus stimulating the proton pump. In hormonal pathway, G cells secrete gastrin, which acts on cholecystokinin B receptors, thus stimulating the proton pump. In paracrine pathway, enterochromaffin-like cells secrete histamine, which then acts on histaminic receptors, which acts by increasing cyclic AMP activity and stimulating the proton pump. Inhibitory pathways include somatostatin, which is secreted by T cells, which directly inhibit the parietal cells and also inhibit the secretion of gastrin and histamine. Prostaglandins inhibit the proton pump by decreasing the cyclic AMP, thus decreasing the proton pump activity. Gastric mucosal barrier is a defense system to protect inner lining of the stomach with the highly acidic gastric juice. It prevents autodigestion and also helps maintain mucosal integrity. The layers of gastric mucosal barrier from outside to inside contains. First is the mucus bicarbonate barrier, which is the bicarbonate ion trapped inside the thick layer of mucus. It provides pH gradient. Second is the epithelial tight junctions, which prevents the back diffusion of hydrogen ion. Next is the surface mucous cells which secrete bicarbonate and hydrogen ion. Next is the capillary supply. The various factors that can affect the mucosal barrier can be aggressive and defensive. Aggressive factors include Helicobacter pylori, non-steroidal anti-inflammatory drugs, gastric acid, alcohol, and smoking. On the other hand, defensive factors include mucous barrier, bicarbonate, prostaglandins, cellular resistance, and mucosal blood flow. Any breach in the mucosal barrier can lead to following applied aspects like esophagitis, gastroesophageal reflux disease, gastritis, and peptic ulcer disease, which are to be dealt later. These are the following references for our presentation. Now I would like to call upon the Department of Pathology for next presentation.
Good morning, dignitaries, esteemed faculty members, and my fellow colleagues. Today, under the expert guidance of Dr. Manju ma'am, Professor and Head Department of Pathology, under the moderatorship of Dr. Deepak Kumar Garg sir, Associate Professor, Department of Pathology, alongside Aslit Sharma, Paridhi Jain, Palak Gupta, Parth Gupta, I, Divyanshi Singh, would like to present on the topic Pathology of Gastritis and Peptic Ulcer Disease. Before we begin exploring the pathology behind gastritis, let us first understand what exactly is gastritis. The term itself, being self-explanatory, literally means inflammation of the gastric wall that can be seen in several pathological conditions. It is termed acute gastritis in the presence of inflammatory cells such as neutrophils, and it is termed gastropathy in the rare presence or absence of inflammatory cells. Let us now look at the pathogenesis of gastritis. The figure to your left depicts a normal gastric wall with a thick mucus layer, the mucosa, the muscularis mucosae, and the submucosa. The physiological damaging factors include gastric acidity and peptic enzymes. The protective factors include surface mucus secretion, bicarbonate secretion into mucus, mucosal blood flow, epithelial barrier function, epithelial regenerative capacity, and elaboration of prostaglandins. The figure in the center depicts an injury, which shows decreased thickness of the mucus layer, some small amounts of inflammatory cells present in the mucosa, such as neutrophils. The injury might be due to increased damaging factors, such as H. pylori infection, NSAID overuse, tobacco and alcohol consumption, gastric hyperacidity, and duodenal gastric reflux, or due to impaired defenses, such as in ischemia, shock, and NSAID overuse. The figure to your right depicts an ulcer demarcated into 4 layers. Going from top to bottom, we have the necrotic debris, the non-specific acute inflammation cell layer showing neutrophils, the granulation tissue showing neovascularization, and lastly, the zone of fibrosis showing deposition of collagen. Gastritis can be classified into 2 kinds on the basis of histopathology, namely acute gastritis and chronic gastritis. The causes of acute gastritis include stress-related ulcers, diaphragm lesions, and gastric antral vascular ectasia, GAVE, also known as watermelon stomach. The causes of chronic gastritis include Helicobacter pylori associated gastritis, autoimmune atrophic gastritis, and uncommon forms of gastritis such as erythrocytic gastritis, lymphocytic gastritis, and granulomatous gastritis. Since our topic of discussion for today is peptic ulcer disease, let us now focus on Helicobacter pylori associated gastritis. H. pylori is a spiral-shaped or curved gram-negative bacilli. It predominantly causes antral gastritis with normal or increased acid production. On long-standing, it can also affect gastric body and fundus. Pathogenesis of H. pylori is based on 4 virulence factors, namely flagella, which aids in its chemotaxis or movement across the mucus layer. 2 cytotoxins, namely vacuolization cytotoxin A or VAC-A and cytotoxin-associated gene protein A or CAG-A. Adhesins, which help in its adhesion to the host cells, and most importantly the enzyme urease, which converts urea into carbon dioxide and ammonia, which is responsible for neutralizing the acidity. Cross examination on endoscopy reveals chalky white ulcers on the gastric wall. Microscopic examination. The figure to your left depicts hematoxylin and eosin stain showing light pink colored bacilli seen floating over the mucosa. The image in the center depicts Walton starry silver stain, which is used especially for the staining of H. pylori, showing black colored rod-shaped bacilli floating over the mucosa. The image to your right depicts Giemsa stain with blue colored bacilli floating over the mucosa. Investigations include serum testing for anti-H. pylori antibody titers, mainly IgG, stool test for the organism itself, and urea breath test, which is a non-invasive test and is also the gold standard test for detection of H. pylori. Complications include peptic ulcer disease, maltoma, and gastric adenocarcinoma. Let us now begin with peptic ulcer disease. What exactly is peptic ulcer disease? PUD refers to chronic mucosal ulceration on the duodenal or gastric wall. It is almost always associated with H. pylori infection, NSAID overuse, or cigarette smoking. Risk factors for peptic ulcer disease include H. pylori infection, cigarette smoking, the use of illicit drugs such as cocaine, and the overuse of commonly prescribed drugs such as NSAIDs. Conditions such as endocrine cell hyperplasia, alcoholic liver cirrhosis, COPD, and neuroendocrine tumors associated with Zollinger-Ellison syndrome, certain viral infections such as cytomegalovirus and herpes simplex virus, and psychological stress. The pathogenesis of peptic ulcer disease is based on increased acid production. That can be due to either increased stimulatory signals as seen in H. pylori infection, parietal cell hyperplasia, and other excessive secretory responses, or due to decreased inhibitory signals as seen in Zollinger-Ellison syndrome. Clinical features of peptic ulcer disease. Now, the duodenal ulcers are about 4 times more common than gastric ulcers. The duodenal ulcers are commonly found in the proximal part of duodenum, just a few centimeters away from the pyloric wall, on the anterior duodenal wall, while the gastric ulcers are found at the interface of body and antrum along the lesser curvature. The duodenal ulcers also show foveolar metaplasia, which is the presence of gastric foveolar cells in the duodenum. The patient presents with epigastric burning or aching pain, iron deficiency anemia, frank hemorrhage or perforation, and pain after 1 to 3 hours of meals, which is mild during the day but progressively worsens at night. It is important to note that the pain of duodenal ulcers subsides after the intake of food, while the pain of gastric ulcers is worsened by the intake of food. Other common symptoms include nausea, vomiting, bloating, and belching. Gross examination of peptic ulcer disease shows sharply punched out ulcers with margins that are at the level of the mucosa. It is important to note that heaped up margins are indicative of carcinoma. Microscopic examination, as previously discussed, shows 4 layers of an ulcer, starting off with the necrotic debris, the zone of inflammation showing inflammatory cells, the zone of granulation showing neovascularization, and then fibrosis. Here are a few resources used in the preparation of this presentation. I would now like to invite the speaker from the Department of General Medicine.
Thank you, Dimyanshi. Good morning, respected teachers. Today, I am Nishtha Sharma, under the guidance of Dr. Puneet Rijwani, Professor and Head Department of General Medicine, under the moderation of Dr. Manish Raspahadia, Professor and Unit Head of Department of General Medicine, along with my colleagues Asta Dangayach, Dhruvansh Joshi, Stuti Dangayach, and Tanish Gupta, is here to present in the 18th UGCR on the topic gastritis and peptic ulcer on behalf of the Department of General Medicine. Gastritis. As the name suggests, Gastritis is described by any histologically confirmed inflammation of the gastric mucosa. It is mainly divided into two kinds, type A gastritis and type B gastritis. Type A gastritis, also known as autoimmune gastritis, is generally caused by the autoimmune destructions of parietal cells, which leads to a decreased intrinsic factor. It is mainly seen in the fundus and the body of the abdomen, and complications include pernicious anemia and increased risk of gastric carcinoma. In the laboratory investigations, the main finding is the presence of anti-intrinsic factors antibody and anti-parietal cell antibody. The type B gastritis is also known as the Helicobacter pylori associated gastritis. It is seen in infections or chronic infections of Helicobacter pylori. It is mainly present in the antrum, but if the infection is prolonged, it can also succeed to the body of the stomach. The major complications include an increased risk of peptic ulcer disease and an increased risk of gastric adenocarcinoma and Mold lymphoma. Generally, in the lab investigation, a positive investigation for H. pylori detection is observed. Now, how will the patient present? These are some of the most common presentations of a patient. They include loss of appetite, indigestion, heartburn, abdominal pain, nausea, vomiting, stomach swelling, or a distended stomach. The symptoms which are seen in gastritis are often very vague. They fall under a broad category of a syndrome known as dyspepsia. These symptoms such as pain or discomfort, burning sensation, bloating, nausea, loss of appetite are generally seen. Along with that, if the syndrome is associated with an active GI bleeding, two major symptoms such as hematemesis, which is also known as in which coffee ground appearance in the vomiting is seen, and melena, in which a black tarry stool is seen, are mainly the hallmark of upper GI bleeding. The definitive role of endoscopy and biopsy. So the gold standard test for confirmation of gastritis is upper gastrointestinal endoscopy, which is also known as esophageogastroduodenoscopy or EGD, along with the mucosal biopsy. In endoscopy, the macroscopic structures of the stomach or the canal are seen, but the macroscopic appearance is often insufficient and can also be misleading. So to accompany this, we also prefer doing the biopsies. The advantages of biopsy is firstly, it confirms the presence of any inflammation by confirming the presence of acute inflammatory cells in the mucosa or the chronic inflammatory cells. It helps in identifying the etiology by using of special stains to identify the H. pylori bacteria. It also helps us to stage the disease, which tells us the severity of the disease as well as if the disease has become precancerous or not. And it also helps us to rule out malignancy and to rule out if the cause is due to any gastric adenocarcinoma or gastric carcinoma. Ancillary or non-invasive diagnostics. The main gold standard test is obviously the endoscopy as well as the biopsies. But along with that, we do a lot of highly sensitive and specific non-invasive or supportive tests which help to support our established diagnosis as well as to distinguish between the type A and type B gastritis. So for H. pylori gastritis, we mainly do the urea breath test and the stool antigen assay. These tests have a specificity and sensitivity of more than 90%. They are non-invasive, easy to do, and are generally highly recommended. For autoimmune gastritis, we do serological test, in which antiparietal cell antibody and intrinsic cell antibodies are generally found in the serum. If the serum gastrin level exceed 1000 picogram per ml, then it initiates a feedback mechanism which often causes gastritis, and also low serum vitamin B12 levels. These are generally seen in cases of malnutrition which precedes pernicious anemia. Peptic ulcer disease. Peptic ulcer disease is defined as a disruption in the mucosa of the stomach and or of the duodenum, which lead to local defect or excavation due to the presence of inflammation. Peptic ulcers are generally of two types. We have duodenal ulcers and gastric ulcers. The duodenal ulcers are found in the first part of duodenum, that is D1. They have a very low risk of malignancy and are 4 times more common than the gastric ulcers. The gastric ulcers are generally found in the lesser curvature of the stomach. They are rare, but if present, they have a very high chance of conversion to malignancies. Epidemiology. The prevalence of peptic ulcer disease is very high in India. It has mainly 2 reasons. Firstly, there is a high prevalence of chronic H. pylori infections in our country, and the second is the increased use of medicines such as NSAIDs. There is a male predominance observed, and also the chances of having peptic ulcer has an increased association with age. Individually, as already discussed, the duodenal ulcer is more common than the gastric ulcer and also more frequently affects people in the 3rd and the 4th decade of their life, whereas the gastric ulcers affect people in an older age, which is more than 50 years of age. Now, the major risk factors for peptic ulcer disease. The first and the most important is the presence of chronic H. pylori infections. Then we have an increased use of NSAIDs such as aspirin. Some chronic habits like smoking or alcohol consumption can also lead to increased gastric acid production. If there is a genetic predisposition or a family history of any gastroduodenal disease, then it may lead to peptic ulcer disease in the patient. Along with that, major physical stressing conditions such as extensive burns and major psychological or emotional stress also lead to an increased gastric acid production or peptic ulcer disease. And some cancerous syndrome or some tumors such as Zollinger-Ellison syndrome also they are also seen in association with peptic ulcer disease. So the clinical features. Now the patient with peptic ulcer disease presents with an epigastric pain. It is the most common complaint seen. The pain is generally described as a burning or gnawing pain, and it is ill-defined aching sensation which often resembles the pain of hunger. Individually, the duodenal ulcer are generally seen after a while, eating after a while. So it is generally seen 1.5 to 3 hours after eating, whereas the gastric ulcers are generally typically seen right after eating. So in gastric ulcers, the pain is in 30 minutes to 1 hour. In duodenal ulcer, when the patient intakes any antacid, milk or food, the pain is alleviated, it is relieved. Whereas in gastric ulcer, there is a food pain association seen, in which if the patient intakes any food, the pain increases. It is especially increases if the food is spicy or if the food has a high fat content. The distinguishing feature for duodenal ulcer is the patient observes a nocturnal pain, in which at night the patient observes pain so severe that it leads to them waking up from their sleep. Whereas in gastric ulcer, due to the food pain relation, the patient experiences a loss of appetite, and due to the loss of appetite, a significant weight loss is observed. Both the duodenal ulcers and gastric ulcers are associated with nausea, vomiting and occasional bloating. Now these are the warning symptoms that may lead the clinician to have a prompt reaction and an urgent referral of the patient in case of peptic ulcer disease. So if there is an unintentional weight loss, if there is progressive dysphagia, there is overt gastrointestinal bleeding, there is iron deficiency anemia, recurrent emesis and a family history of upper gastrointestinal malignancies. Physical examination. So the examination of patient has revealed epigastric tenderness, but the predictive value of epigastric tenderness is really low. So as to discover any evidence of any complication of peptic ulcer disease, some physical examinations are important. So firstly, tachycardia and orthostasis. They represent that there is a dehydration present in the body, which is secondary to vomiting, and it also seen in active GI bleeding. The second is the presence of suction splash. It is seen when there is retained fluid in the stomach. This retained fluid is generally suggestive of a gastric outlet obstruction. And the third is a severe, tender, board-like abdomen, which is generally seen in perforations. Now the diagnosis. Firstly, the clinical diagnosis. The clinical diagnosis is mainly done on two bases. The first is the clinical symptoms and the second is the history cues. In the clinical symptoms, as already discussed, the patient will come with an epigastric pain. They will show a food and pain association or that the pain is alleviated by taking the food. They also show nocturnal pain, they show bloating, early satiety, weight loss, etc. In history cues, we take in account of the risk factors, such as if the patient has a chronic use of NSAIDs, if the patient has a smoking habit or a drinking habit. But these clinical features, they are not really distinguishing between if there is peptic ulcer disease or there is functional dyspepsia, if the disease is duodenal ulcer or gastric ulcer, or if it's a benign or a malignant tumor. So peptic ulcer disease is not a purely clinical diagnosis. We need to make efforts into doing some laboratory investigations for our confirmation. So the main investigations for peptic ulcer disease. There are 5 main investigations. The first is endoscopy, test for H. pylori, biopsy, radiological investigations and laboratory investigations. Endoscopy. Endoscopy is the gold standard test. Endoscope is an instrument which has a camera and a light connected to it, which when introduced into body canals help us visualize the structural integrity of the canal. So the first picture here shows the normal endoscopic image of a normal gastric fundus. The second picture we can see that there is a benign gastric ulcer in the antrum. And in the next picture we can see that there is a malignant ulcers which has involved the greater curvature of the stomach. These two pictures here show the normal endoscopic pictures of a duodenum. The first is the normal duodenal bulb and the second is a portion of duodenum. Now the picture here, the first picture shows us an ulcer which is a small pigmented spot on the base. In the second picture, you may notice that there are some presence of some vessels. These vessels are indicative of a recent hemorrhage that is very common in peptic ulcer disease. Helicobacter pylori testing. As we have already discussed, it is one of the major causes of peptic ulcer disease. So to distinguish that if the presence of Helicobacter pylori is there or not, we have two kinds of tests. Firstly, non-invasive test and then invasive test. In non-invasive test, we have the most common gold standard test, that is the urea breath test. As discussed, it is highly specific, highly sensitive, easy to conduct. It is most preferred. Then we have stool antigen test. It is also an easy to conduct test, but it is cheap, inexpensive, and it is generally used after post-treatment confirmation of the disease diagnosis or post-treatment confirmation. Serology is not generally used because it cannot distinguish between an active infection and also a past infection. Invasive tests or endoscopic biopsies. So the first is rapid urease test, in which the biopsy is kept in the urea medium, and if a color change is observed, we say that it is positive for the presence of H. pylori. Histopathology is the gold standard test in which H. pylori along with some inflammatory cells are observed as seen in the image. Molecular tests such as presence of PCR for detection of H. pylori are generally done, and culture is rarely done, generally done for research purposes. Now the radiological investigations. These two images here show the benign duodenal ulcer and the presence of benign duodenal ulcers. The pictures on the screen here, they show the radioscopy of presence of gastric ulcers. The first one show a large gastric ulcer along with the location of the ulcer. Laboratory investigation. So, as discussed earlier, various laboratory investigations such as hemoglobin and hematocrit. This is done in cases where active GI bleeding is present, and in this anemia and chronic blood loss is seen. Stool for occult blood, again done where there is active GI bleeding. Serology, stool antigen test, urea spread test done for H. pylori. Serum gastrin level. This is very important because it is elevated in Zollinger-Ellison syndrome. It is rare, but it is an important differential diagnosis and should be ruled out. And serum urea and creatinine level. These are elevated in upper GI bleeding. Now for the treatment. As a clinician, the role must be firstly to relieve the symptoms of the patient, which are generally pain and dyspepsia. After that, they should be to promote ulcer healing, and lastly, to prevent the ulcer recurrence and also to prevent the complications. Along with that, major lifestyle changes should be done by the patient, such as smoking and alcohol full remission. They should have a clean diet, prevention of stress-inducing activities and stress-inducing triggers. So the major drugs which are used are of two types. We have the acid-suppressing drugs and we have the mucosal protective agent. In acid-suppressing drugs, we have proton pump inhibitors, H2 receptor antagonists, and antacids. In the mucosal protective agents, we have sucralfates, prostaglandin analogs, and bismuth compounds. When patient comes, the standard therapy given is a standard triple drug therapy, which has three drugs. Proton pump inhibitor. These proton pump inhibitor, they act on the hydrogen potassium ATPase pump and they inhibit the last step of HCl production, which in turn inhibits the HCl and which in turn inhibits the peptic ulcer disease. It also helps to increase the efficiency and the potency of the antibiotics that are given. Then we have clarithromycin, and which is a we give clarithromycin, which generally acts by inhibiting the 50S ribosomes, which decrease the protein production in the bacteria. And then we give amoxicillin, which generally helps by inhibiting the cell wall production in the bacteria and in turn inhibiting and killing the bacteria. This standard triple drug therapy is followed right now. And if it is a first line therapy, but if it is not effective, then we do the second line therapy, which includes adding some of the stomach protective medicines such as bismuth based compounds along with the first line therapy. Thank you so much.